All right, it's 9:30. We will start the session. First of all, I would like to thank you all for joining, and I would like to share with you today is a very special day. We're going to have a discussion from experts who have done a lot of work in optical diagnosis of colon polyps. And we have experts joining from different parts of the world. This is really exciting. We all can learn from each other. And I would also want to make an announcement that is very special to me. And that is Dr. Selvi Tirumurthy received her promotion to full professorship at the University of Texas MD Anderson Cancer Center. So let's give her a big hand and congratulations, Selvi.
Raju, thank you, everyone. Please, Raju, you didn't say you were going to do this. But thank you, everyone, very much.
So, you know, it's very important. I think in an academic career, that's one of the things we all want to reach. It's a big deal, Selvi. I'm really delighted. Now that you don't have any pressure, you can spend all your time on Zoom classes.
Thank you, Raju, for your friendship, your leadership, your mentorship, and your support of me and my career. Thank you.
So as part of this, I'm really delighted that Roy, Tanya, Sylvia, and Ravi agreed. Why don't we take a few minutes for each of the panelists to unmute and introduce about themselves and what they're passionate about. Roy?
Good morning. I found this part of the talk always the most difficult part. I'm very pleased to be able to participate in today's conference. It's really a pleasure for us. I think let me just put it in 2 sentences or 3 sentences. Much of the work that we are doing in optical diagnosis actually have derived, or we had the opportunity to participate in it. Whether it is the equipment that you use from the endoscope to the monitor to the classification have probably been touched by some of us at the VA Palo Alto throughout the years. The nice classification and the teaching of it have also derived from our work there. Sylvia came from Maastricht some 10 years ago and brought the idea of the flat lesion to Europe, and now Ravi from Singapore. But what we realized is that the teaching of nice classification has been kind of stalled, and we are trying to do our best to uninstall it. And this is one of the efforts that we are doing today. So thank you so much for the opportunity.
Right, my good friend, thank you. Sylvia, could you kindly say a few words about yourself? We are delighted that you're here. I always enjoyed listening to your beautiful talks at DDW.
Thanks a lot for having me in this important meeting. And it is a great honor and pleasure to participate and to bring my experience in this field and to help the trainees. Thank you so much.
Thank you, Sylvia. Ravi?
Hi, everyone. Thank you very much for this opportunity. I'm in fact glad that I'm a part of this great talk. Much of this about optical diagnosis, or the bulk of this, I learned from Roy and Tanya and yourself. So it's always nice to hear it back from the teachers. And it's great. Thanks for having me. It's going to be a good learning lesson for me.
Thank you, Ravi. Tanya?
Good morning. Thank you, Raju and Roy. and your group for inviting me to join as well. Optical diagnosis has been a great interest of ours, as Roy alluded. When I trained with Roy, this was one of the first things I became very interested in colonoscopy, and it's carried forward. And I'm very interested to continue disseminating this practice, the idea of it and the practice of it. And so thank you for creating the opportunity today to do this.
All right. Thank you, Tanya. Thank you. And I really appreciate you joining despite all the setbacks in San Francisco. Our prayers are with you all in San Francisco. So I would like to, first of all, acknowledge, we need to make sure that we acknowledge the support because none of these educational events happen without the support of donors and supporters. I would like to acknowledge the support of Dr. John Storline, my mentor, Mr. Charles Butt of HEB for providing a grant, and Ms. Angela Deal, medical illustrator who created a lot of illustrations, and my university for allowing me to use this Zoom to teach. So the learning objectives are as follows. We will cover 4 important topics. That is how to be a good photographer as an endoscopist. And then Roy and Tanya and the group will talk about the NICE classification to give you a little bit of background and help you learn about the different aspects of NICE classification. And following that, we included 24 cases. We present a case and then we do a polling for you to share what you've learned, identify whether it's NICE 1, 2, or 3. And the polling will be organized by Sylvie. And then finally, we will wrap it up with another video. So one thing is, most endoscopists may not realize they are blessed with a camera in their hand for a long period of time. And I wish we utilize the camera to the best of our abilities and to also help our patients as well as our colleagues in providing education. So make sure that we use the camera aspect of the endoscope to the maximum benefit. So as far as the camera of the scope is concerned, we have basically 4 different buttons. One for freezing the image, another one for capturing the image, and then special functions like chromoendoscopy. With Olympus, it is narrowband imaging. With Pentax is eye scan. With Fuji, it is FICE. And then another important function is the ability to focus the image a little bit better so that you get the granularity of the image by using the near focus function. So we have 4 different buttons, as you can see here, on an adult colonoscope. The near focus function is not available in the pediatric colonoscope. Otherwise, adult colonoscope, adult EGD scope, they have those 4 functions. And we want to make sure that we utilize all those 4 functions to provide the best imaging and diagnosis of a particular lesion. So first thing is, when you are doing an endoscopic examination and when you see a lesion, the best way to figure out what is happening with the lesion is to freeze the frame. When you freeze the frame, you have the ability to take time and look at the lesion in detail and figure out what is happening. I think freezing the frame and trying to learn what is happening with the lesion is the first important concept you want to get into as an endoscopist. And once you feel that your frozen frame is good enough for your records, then you could press the capture and use that in your report. So the most important thing is freeze, and then the next step is capturing the image for your records. In addition to that, when you see a polyp or when you see a flat lesion, whether it's a Barrett's or early gastric cancer or a flat lesion in the colon, you have now the ability to use narrowband imaging. And once you press a narrowband imaging button, you see the narrowband imaging. And then again, you can figure out whether you want to freeze and examine and then capture. All right. So when you see a lesion with an adult colonoscope, you have another useful function that many of us do not routinely use. And I've learned how to use it by talking with Roy, and that is near focus function. When you have a near focus function, you get a lot more details so that it helps you to have better optical diagnosis with a greater confidence. And again, when you use a near focus, then the next step is again, freeze and capture for your records. So these are the basic tools as a photographer for you to evaluate a lesion, document the lesion, and keep it for your records. So I would like to share with you a short video that I've actually recorded just on Friday, just for this course. So this is what I do, wash. And we found a small lesion. Take a white light photo, use NBI, take an NBI photo, and then apply near focus. And when you see with near focus, you see much finer details, and take another photo. And then finally, you may want to remove it with a cold snare because the latest guidelines do recommend that any polyp more than 3 millimeters should be cut with a cold snare. As you can see here, I want to leave some of the other concepts that I want to talk about later. For a young trainee, it is important to get into the habit of freezing, capturing in white light, NBI, and near focus. As you get better, you don't need to do all the things that I've talked about. If you want to have one good diagnosis, you could have one image that is near focus with NBI that gives a lot of details. So I will stop here, and then we go to the next session where Roy is going to take over and talk about nice classification.
Thank you, Raju. I want to spend a little bit of time to introduce the NICE classification. This classification is the result of work by many, especially from our Japanese colleagues who started this endoscopic diagnosis some more than 10 years ago now. And by the time of about 10 years ago, a group of us, a couple from the US, Tonya and I, a couple from Europe, and then Australia, and then also Japan, get together maybe twice a year to decipher, well, now we call it deconstruct, what it is that an endoscopist see when he or she encounters a polyp using the narrowband imaging. And it took quite some time, I think about 10 meetings before we could come up with the NICE classification, which was published in 2012. And then subsequently, there was a lot of effort to create the equipment that can do this very well. Raju mentioned, for example, that it can only be done by adult colonoscope. That is no longer true. We have participated in fixing that issue. So there is a solution for that now. And then the field kind of stalled when it seemed to be that only the experts can perform the NICE classification, and it didn't work so well when it is given into the widespread use. And more importantly, it turned out that it requires the FDA to approve that endoscopes can be used to perform endoscopic diagnosis. That effort to get the FDA to approve it took some more years. And we are very, very pleased that the FDA actually gave the approval that recognized that from now on, colorectal polyps, especially the diminutive ones, can actually be diagnosed using the endoscope. That is a major, important recognition, because never before we could use the endoscope and make an in vivo diagnosis of a colorectal polyp. So that has changed as of about 2 months ago. What also have changed is that our group have refocused our efforts to teach, and we suddenly realized that a lot of our efforts for the past, for me, for the past 20 years, actually have not focused on the right pedagogy. So here we, for the past 2 years, have been using a different pedagogy. And as I said in the beginning, we wanted to use some of it in this meeting today. So in the first part of the learning of the NICE, I'm just going to have a discussion with Tonya, Rafi, and Sylvia. And the purpose is that we wanted to transfer our knowledge of what is it that we see when we encounter a polyp. What is it in the detail of this polyp, for example, that is in front of us that makes Tonya to think that this is type 1. So let us begin. There are about a dozen of these slides, and we hope that by the end of this short exercise, we all can recognize the thinking patterns that an expert in optical diagnosis uses as we are trying to classify these polyps. So Tonya, let's begin with this polyp. We talk about the NICE classification. So again, what we meant is look at color, vessels, surface. So always think color, vessel, surface, 3 things. And they are actually not that complex. So first, Tonya, how many polyps do you see here?
I see, let's see, about 6 polyps.
Okay. And why is it that one of them is very detailed in front of us?
The location of the polyp, the focus of it, it's the closest to the lens. Okay. And it's the one that is in focus. And so we're seeing more details.
So that NICE type 1, when you look at it, you talk about this same or lighter than background. What do you mean if you look at these 6 polyps?
So my eyes are first drawn to the polyp itself at 6 o'clock. And I see like a whitish color at the bottom and a brownish color at the top of the polyp. And if I look at that and contrast it to the surrounding, it's about the same, if not paler at the bottom than the surrounding normal mucosa. And so when we look at color of type 1, we're seeing, is it darker or is it the same or lighter than the background, than the surrounding normal?
Okay, would you say that there is at least one out of the 6 polyps that's almost the same color as the background?
I would say the one at 9 o'clock is about the same color. The others, based on, again, like the position and the angle and the lighting, look pale and they look lighter than the background. But the
Okay.
9 o'clock one may look the same. And the top of this one that that's in focus also looks the same.
Okay, very good. So that's what we meant with color. And again, the color that we talk about is based on the narrow band imaging. So let's talk about vessels. Do you see any vessels in any of these 6 polyps?
I don't see vessels in this polyp.
What about these black dots? Aren't they like vessels like in the esophagus?
No, the black dots here are the crypts. You can see they're uniform, they're circular, and they're kind of homogeneous throughout the polyp. Those aren't vessels, that's the crypt of the polyp.
So the crypt is like the hollow structure, cylindrical going down and surrounded by glands, which is cells. So here, would you say this whitish structure around it is the glands?
The white surrounding those crypts, yeah.
Yes.
Yes.
Okay. Okay. So now we agree that there is no vessels. So the nice type 1 says no vessels or isolated lacy, and we are going to show what isolated lacy is. So let's talk about surface pattern. What do you mean with surface pattern? Are you talking about the bumps, the valleys on the surface of the polyps, which some surface have, the nodules that some polyps actually some polyps have? What is it, surface pattern? What does this word actually mean?
Yeah, we're not talking about morphology, which I think is what you're referring to in terms of bumps and nodules and such. We're talking about what we see on the surface that's not the vessels. So the pattern of the polyp that's not vessels. So those crypts, the glands, that's what surface pattern means. What we see when we look at that polyp on the surface, that's not vessels.
So surface pattern, I think the nice classification people who develop, the developers meant is that anything on the surface that's excluding the vessels. And we will see what that means later on in type 2. Surface pattern is not the bumpiness of the surface. And here we talk about dark spots. And Tonya said those are the crypts. So I see some crypts to have lesser dark spots. What do you mean with that? Why is it like that? And we can promise you this is the only physics that you ever would want to know for these.
Yes, so the reason with the type 1, the surface patterns dark or white, is because sometimes those crypts actually look white depending on the light. So if the light is shown back to us, it looks white. If the light is absorbed and not, it looks dark. And you can speak to this more, Roy, but that's how I think about it, and that's how it helps me think about, well, why are they dark or why are they white? And it's the same crypt or same pattern.
So it's dark because you think it as it's a dark hole. All of the lights that go into this particular crypt is actually cannot come back out, whether it is because of the shape of the crypt, the depth of the crypt, the diameter of the crypt. The light just get entrapped. So to our eyes, through the CCB of the endoscope, there's now no lights coming back. So some crypts are dark, other crypts could be white. Okay? And their shape is either round or star shape. Okay, let's talk the next slide, please.
So it's type 1, color vessel surface pattern.
Raju, next slide. Who's controlling the slide?
One second. Just bear with me. It got a little bit frozen.
No.
Okay.
Okay.
Go
So
back
let's
one.
okay. Let's talk about this one. We'll go a little bit faster now. What does lacy mean? Is there only one lacy vessels, or is there more than one lacy vessels? Tonya?
So, sure. When I see this polyp, I see multiple vessels. They're scattered on the surface of the polyp, and I would consider all of them lacy. The arrow that is shown is the thickest lacy vessel, but lacy vessel is, it sort of courses across the polyp. You can't really see a definitive start and stop that surround a gland, for example. It just, you sort of can follow it, and then it tapers. And so that's a lacy vessel. And
Okay.
they're not one size or diameter or thickness. So you can see a thicker one with the arrow, but you can see thinner ones scattered all over this polyp.
Okay. So when you see lacy vessel, is that pathognomonic for a hyperplastic polyp? Is it very important to have this lacy vessel?
Well, some type 1s don't have vessels, but if we see these lacy vessels, it is characteristic of a type 1, whether it be hyperplastic or a sessile serrated lesion. Type 1 have lacy vessels.
So if you see a lacy vessel within 1 second, 2 seconds, could you say this is for sure is type 1 with high confidence?
It would be one feature that would give me high confidence that it's a type 1. I would look for the other color or surface pattern. I often look for at least 2 of the features to give me the highest confidence. But this gets me close.
Next, Raju. Okay. Here, is this what you mean, that there is no pattern, homogeneous absence of pattern?
Yes.
It just looks bland.
It looks very bland. You can try to create a pattern here with the dots, or you can even try to create some of those lacy vessels, but it's fairly bland.
Okay, next. Okay.
And this is similar to the last. I think this is a kind of a similar type of patterns.
Okay, let's contrast these findings to type 2. Okay, what is so different in the, again, think color vessel surface. Tonya, just briefly, what's color vessel surface that's so unique about this polyp?
Well, I mean, I think strikingly right away, it's more brown. And then you see the vessels here and you can follow them. You can like follow them around the surface structure. And the surface pattern here is variable, whereas in type 1 it was very homogeneous and uniform. In type 2 they're variable. You can see here these vessels surrounding each crypt, and the glands here, or the surface pattern, are tubular. They could be long tubules, short tubules. They can almost look like ovals. The variability in the surface pattern is also a striking feature. So it's dark. It has these vessels that we can outline the tubular structures with, or oval structures, or short tubules with.
So transfer your thoughts for a second here. If you see this white structure surrounded by brown, they are variable in size and shape. Are those like pathognomonics? Are you like done with this? High confidence, done. This is adenoma.
High confidence type 2.
Okay. Next. Raju.
Just 1 second. I think I may need to stop using the...
Yeah, you need to stop drawing it. It got stuck after everyone.
Okay.
Okay. Again, I think you see like these white structures, right? The whitest surface patterns. They're long, some of them long, some are round, some are maybe pentagonals. So Tonya, are you done? Ravi, are you done?
As previously discussed, It's brown in color, and we see the blood vessels. And between the blood vessels, we see the whitish structure, which is elongated. And based on the description, with high confidence, we call it as adenoma type 2.
Okay, next. Now this one is like, it doesn't take like even like a second. It takes less. So why is that, Tonya?
It just has all the features in it. They're striking. So your brain sees it immediately. It sees the brown color. It sees those blood vessels, and it sees the tubular structures.
So when you see these variable white patterns, the tubular structures, you're almost like, I see the brown things, and then I'm done.
Yeah,
okay,
I think
next.
that, yes.
Okay, what about now? Is this, this must be an adenoma or high-grade dysplasia, right?
Well, walking back, yes, but the nice classification is for NBI, and it's for closer. You can't see the details of the vessels or the surface pattern yet.
Okay, how about now?
It's brown, and I'm starting to imagine them just from all the polyps you've seen in all your career, but I don't know for sure.
Okay, next.
So you get closer, yeah. So now you can see clearly the brown color relative to that normal on the right. You can see the blood vessels surrounding those variable structures, tubules, octagons, pentagons. You see all the shapes, and that's very classic. And the patterns continues, there's no loss of it. So this is adenoma with high confidence. I'm not concerned.
So, but then for this, aren't you like worried of the possibility of a high-grade dysplasia and such, or even invasive cancers?
Yeah, that's what I was hinting at. From what you've shown me right here in this image, I see pattern throughout, and the pattern is regular, meaning I can see the tubules and the shapes and the blood vessels throughout. There's no loss of that. There's no change in it that suggests type 3 morphology.
So the presence of pattern is very, very important. Next slide. Now, what about these? What do you guys see? Let's start with Sylvia. Sylvia, what do you think?
This is a quite complex lesion. It's, let's say, about 3 centimeters in size. It's a flat with a central depressed area, in my opinion. When I look to the color, there are areas of brown, dark areas relative to the background, but there are also in the central part, in my opinion, some whitish areas. When we look to the vessels, again, we see area at the periphery, which do show a vessel pattern, the areas of disrupted vessels, but in the central part, again, I can't identify the vessels. There are no clear vessels.
Okay.
And when we look to the surface pattern, I see actually in the central part, again, no surface patterns. So in my opinion, this is a deep submucosal invasive cancer in a large adenoma. So there are still some features of adenoma in the periphery, but the central part clearly shows signs of invasive cancer.
Okay, so here we wanted to transfer our thinking that when you see the vessels on the periphery of this lesion, the brownish structures, those are blood vessels. Those blood vessels have pattern. The dots in the middle, okay, those are probably the dots of the crypts of the lesions. There is no pattern. In some lesions, it is just a pure ulcer and there is no pattern. Those are what we call amorphous or absent. When you have that, then you should worry about submucosal invasion. Now, in the next few slides, we're going to discuss about some features that that's outside the NBI, but helps you to think about submucosal invasive pattern, because submucosal invasion is very, very important to be recognized. You do not want to be cutting something that has a submucosal invasive pattern. Okay, let's talk about expansion. So if you look at the polyp on the right side, or the lesion on the right side, the fold from the bottom, it starts to be thin. As it goes into the middle of the lesion, it becomes like thick. And that's what we call expansion. Why is it expanded? There are only two reasons. One is either you have desmoplastic reaction to the cancer, or you have invasion of the cancer itself. Either way, it means submucosal invasion. Next. How about this one? There are fold convergence. So these are folds that shouldn't be there. Actually, if you look at the picture on the left, you see there's fold. There are at least 3 folds towards this tumor. And on the right, there is the picture on the right, there is one fold starting from the left that becomes expanded. And then there are 2 folds from the right side coming into the lesion that are converging into the lesion. Why would they be converging? It's like the tumor is like pulling these folds together. So these are the fold convergence. Next. Fullness. Fullness is like there is something inside this lesion. It looks like, I don't know how to say it except it's full because there's something growing in it. And fullness is a submucosal invasive cancer. Next. The last part is that if one tries to cut, of course, it would not lift because the lesion is invading into the musculus propria submucosal layer and is tethered, so it will not lift. This is the non-lifting sign. Ideally, of course, the lesion would be lifting up, but it's not. Okay. Tonya, let's talk about the amorphous area. What do you think about the amorphous area?
In the white light, I'm seeing a lot of white and then some scattered red. Red are usually blood vessels. So I'm thinking that the absence of the red with all that white is an amorphous area. Do you have another image?
No, we don't have the NBI, but what we wanted to say is that amorphous is really like when you have no pattern. Mm-hmm. Sometimes it's just like the inflammatory layer of dead tissue on it. Sometimes it's like an ulcer or an erosion, but really there's no pattern. An amorphous area is a very important findings because it tells you that it is most likely is an invasive cancer. Next. So now we are coming to the second part of the training of the NICE, and we are going to do the polling method, and we are going to talk about what it is that makes it pathognomonic, and what is it that that makes it not, and what is it that also could cause like confusion. I think maybe we just focus on pathognomonic and what is it that cause confusion. Okay, this is a polyp. This should take a high confidence very quickly. Next slide, polling. Please poll, please. Do they know how to poll?
Yeah.
Okay.
So what I suggest is for the participants to pick, and because of time limitation, I think we're going to have maybe about 15 to 20 seconds. And I want everybody, we have 94 people registered. So, and after
okay.
10, 15 seconds.
Let's just take turn. Tonya, why is it, it's a high confidence, it's simple that this is type 2?
Well, if you recall the image of the polyp, again, it had the striking features, color, it had the blood vessel, and it had those tubular structures. So high confidence operationally is like that. You have 2 of the nice features. I think that boosts your confidence if you have 2 of the features of color, vessel, or surface pattern present. It also, we looked at the time it takes. So if you can make a guess or a prediction within 5 seconds, it's generally that you have a lot of confidence in that. But if you're looking at a polyp and taking more than 5 seconds, it's unlikely that your confidence should warrant you to make a decision on that management, and that a biopsy is a good.
Okay, so let's go CVS. Brown vessels, right? And then you have the surface. These are white tubular structures, variable size, shape, and length. Easy. This is high confidence. Next. How about this one, Ravi?
Do you want to poll
Okay.
first?
Do you want to poll?
Oh yeah, poll first. Ravi will discuss. If you could go back to this picture. Huh?
I think now that people got used to it, what I'm going to do is I will show the lesion and leave the lesion on, and we'll start the poll.
Okay.
And we'll go to the result.
Awesome.
All right.
Okay, let's hear your poll. Great. Okay, let's see the picture.
Okay. All right.
Ravi, let's start. Why is it type 1?
So let's apply the same concept, CVS. So color, it's not brown, it's same as the surrounding. And then vessels, we don't see any vessels. There is no lacy vessels. And the last one is the surface, we just see white spots. If we put all these things together, it fits for a hyperplastic polyp with high confidence.
Uh-huh.
All right.
So, Tonya, why do you think people could be thinking this could be type 3?
I think that it was quickly shown, first of all, and there is this fullness next to the scope. And so I'm wondering if that, it just wasn't enough time to appreciate the lesion.
Okay. Next slide, please. Okay. What about this one? Sylvia. Oh, the poll, please, poll. Okay, Soviet, briefly.
This is a small flat adenoma. When we look to the color, actually, is this a near focus image, if I may ask? It's a very small lesion, so I would like to go a little bit closer to inspect the vessels and the surface. I think, in my opinion, the blood vessels can be visualized, brown vessels, but very subtle because it's a very small lesion. And when we look to the surface, we see tubular structures surrounded by vessels. I think that this is an adenoma with, let's say, not the highest confidence, but high confidence.
Uh-huh.
And
Okay.
I think the confidence could improve, as Sylvia is suggesting, if we got a little bit closer.
Yeah.
Okay. Okay. Later on, we are going to talk about a pathognomonic that we haven't discussed yet. Okay. But I don't know if you can see my hand. If go back to that polyp, Raju, and we are going to introduce the concept now. If I had put the polyp just like this on my hand, and I imagine that if I suction the lumen, the polyp will collapse at a horizontal line. It will collapse like this. Okay.
One second, Roy. You may need to show, because I've.
Okay, that's okay.
Okay,
What I want
you can
to
show the hand.
Okay.
Okay, you describe that again.
Okay, this polyp, if we imagine it can be folded, okay, it can fold in the along a horizontal or even a vertical axis into like one folded part. Okay, this is the polyp can fold. So that part is what we call the Falley sign. Okay, and only adenoma has a Falley sign. Later on, we are going to have many polyps that has Falley signs. And when you have a Falley sign, it's a very specific findings. That's pathognomonic for an adenoma. Okay, next. Okay, let's Paul. Okay, very good. Tonya, explain once again, Falley sign. What do you see a Falley sign in there?
I do see a valley sign. It's sort of basically you see the periphery of the polyp and then it tapers down towards the center like a valley. And so I see a valley sign in this polyp.
Uh-huh. So think about it like your hand, you can like, you can flex it and then it can fold. So here you can like fold the polyp left and right and then make it into one thing. That's a Falley sign. And that's a pathognomonic. You're done. You don't even have to like consider anything else. This by the specificity of it, this is an adenoma. This needs to be resected, cut, or sent to pathology. Next.
Do you think we should call that not only as a value sign, but almost like a saucer? It's actually like a saucer.
Maybe. So the Falley sign, if you look at the document that we had sent you, is at the very bottom of the NICE classification.
Okay.
Okay, next. Okay, what about this? Pathognomonic, not pathognomonic. Ravi. Paul, please. Okay, let's discuss. Ravi?
So it's brown in color. We can see the blood vessels on the polyp, which is also brown. And in between the blood vessels, we see whitish elongated structures. It would be better appreciated if we were quite closer. But based on the image, it's an adenoma with high confidence.
Okay, great. Next. Wow, this is more difficult. Paul? Tonya?
Okay, we'll let them do the poll first and then I can.
Yeah, but you just get telling you to get ready.
Sure, sure.
So 30% adenoma, 22% low confidence, and 46% cancer.
Uh-huh.
Okay,
Let me ask Tonya one question first. Why is it not cancer?
I see a pattern. I do see what we've taught about the amorphous because it is missing in the center here and there. It's missing these patterns, but I see overall a pattern there of an adenoma. The blood vessels, the structures we talked about, and I would consider it may have some high grade, but this does not have deep submucosal invasion, which would be type 3. This is still within the type 2 classification.
Okay. So this is not what we meant with amorphous. We will talk about amorphous more with more practice. Okay. But before we move on, I'd like to hear a more definitive definition of high confidence and low confidence. Maybe Tonya can explain that.
Sure. So, I mean, in this case, I have high confidence that it's a type 2. And I have that because of the features that it's showing from the NICE in type 2 that I highlighted. And it also, if you then take it a step further to give more confidence, if you didn't have that, you could then use those features of the morphologic, the fullness, the fold convergence, the features that give you submucosal invasion. It doesn't have any of those to bring your confidence back to type 2 if you started to go to type 3.
Mm-hmm. So philosophically, right, high confidence, low confidence is like this. You go to your radiologist and say, what do you think of this chest x-ray? And they say, well, I think it's probably an infiltrate, but maybe I'm not as certain. Okay. So in the diagnosis of through the endoscope, we also need to have that, and we need to codify it. And that's why we meant by using the high and low confidence. It's like the radiologist could say, like, for sure there is a nodule there. I'm highly confident there is a 2-centimeter nodule there. But then sometimes the radiograph could be just a little bit uncertain. And then you say, well, maybe there's this shadow and things like that. So that's the concept. And like what Tonya had said is that if there's at least 2 criteria, if there is a rapidity in making the diagnosis, those are high confidence. And they may, or they will play more of a role in the treatment. It guides us into the treatment.
Next. And can I just make one more comment about that, Roy? The beauty of using confidence, high or low, it allows you as the endoscopist to gauge your management. And when we studied this in a randomized way, and we found that high confidence was a really good clinical gauge. So when you make a prediction with high confidence, your accuracy in the polyp prediction is really accurate. It's really good. And so across endoscopists, when you use confidence in it to guide the optical diagnosis, when you use this variable, it gives you accuracy. So some people may have 80% of polyps they approach, they may apply high confidence to, and some people may have 60% of the polyps that they see, they apply high confidence to. So you can always try to improve your confidence as you gain experience with more and more polyps so that you can act on them. But using confidence is really, really important when you're going to make clinical decisions with the polyp, because not every polyp is a slam dunk type 1, 2, or 3. Some of them have variability that are confusing and you would have low confidence.
Okay, next.
I have a question, Roy.
Yeah.
With regard to the same polyp, if you see of all the polyps that we discussed, many of them got this wrong. So the question is, compared to the previous adenomas which we saw and this one, the one thing which is slightly different is the regularity of the vessels. In the previous polyps, we can see either they are long or they're like they're curved, but here we could see that the vessels have a different pattern. How do we ensure that everybody appreciates it and makes a correct call of adenoma based on the vessel appearance?
I go with like vessels and then what it surrounds.
Like if we have a previous adenoma picture, like the slam dunk straightforward adenoma, if we see that, if we can move behind, and then if we look at this polyp, we can see that there is a lot of difference.
Yeah, Tonya, maybe you can answer, Ravi.
Well, I think that, I mean, you want to know, Ravi, why is this not a type 3?
Yeah.
So I think the irregularity of the vessels is still okay. I think that what may lead you into the type 3 is that loss of vessels on the surface in the middle, right? Mm-hmm. But I would get even closer and see, but it's just those 2 little areas. And I mean, what this would drive me in clinical practice is I would make sure I took this out in one piece and we would get good pathology. And it may be, this is a type 2 low confidence, I think. So I think that that's fair to think of it that way.
Okay.
Roy, Tonya,
let's look at some more example on the type 3, and then I think we will get there. I'm hoping to like get more people to understand what is type 3 because it's so important.
Roy, may I comment regarding this the lesion you have previously described? In my experience, sometimes it is difficult to predict histology based on a set of still images only. In real time, we can insufflate or desufflate, we can get closer, we can move and change the angle. So we have more possibilities to better visualize the lesion and differentiate between type 2 and 3, or when there is uncertainty, when we can't predict with high precision, with high confidence.
Okay. Okay. What about this one? What do you guys see? Already been decided. Okay, why is this not an adenoma? What is there a pattern mnemonic?
Yes, there is.
Okay, Sylvia?
I think that the lacy, isolated lacy vessels are quite clear, coursing across the lesion. And although I don't see dark or white spots, I think that there is a homogeneous absence of pattern, and the color is lighter or similar to the background. So
Okay.
this is a high
Yeah.
confidence.
So this one has pattern mnemonic findings. We are done. We look at lacy vessels, done. Next. Raju, okay. This is a little bit smudge. What do you think? Let's talk. I wanted to, somebody just texted me and said, I'm confused about the Phalli sign. Tonya, tell them again about Phalli sign. It's very important. If we just learn about the pattern mnemonics, there are so many things we can just resolve within seconds. I don't have a voice. You mute yourself.
Sure. We may have a few more Valley sign examples because I think once you see them, but essentially the Valley sign, it's in the center of a polyp, and you start to, it may be a little more white or it may be a little more brown, but it's a morphologic description. So it's not within the color, surface pattern, and vessel of the gneiss. It's actually, it's separate, it's morphologic, but it's essentially a tapering or a valley in the center of the polyp. And so in this case, I see a valley. It's very subtle in this one. I think it might be easier to appreciate from obvious valley signs first, but
okay.
This is a
Let's
valley
draw
here.
a line from 11 o'clock to about 5 o'clock, straight line across the polyp. And imagine that the polyp can be folded along those lines. That's the valley. The valley is from 11 to 5 o'clock. And it has a different pattern of the vessels in there. Okay, next. Wow, is this a valley sign? Let's see what the poll says. Okay, a very important poll. Sylvia, just very briefly, touch like the very important findings and say, for sure, this has to be cancer. How do you say that?
It is darker than the surrounding mucosa.
No, give me a pathognomonic.
Amorphous sign. There is
Okay.
no.
So this is why it is so important that we understand about the amorphous sign. There is amorphous sign here, and it is on the right upper quadrant of the polyp. Just look at that. There is no findings there. It's just bland. That's cancer. It has many other features of cancer. It's full. It seems to be like, that area is amorphous. It has a depression, but we won't talk about it here. So this is a type 3. This is pathognomonic. It's simple, it's easy. Okay, next. What about this one? This is confusing. We've never seen this before. Paul? What do you do when you have things that don't really fit? What do you see, Ravi?
So the polyp is very red on white light. And then when we look on NBI closer, it's again, we can see the vessels, but we don't see any structures, clear structures between the vessels. So this is low confidence, looks like inflammatory polyp, or if at all it is, I will just go low confidence adenoma.
Okay.
It's
Tonya,
inflammatory polyp.
how does this fit to the low confidence definition in your mind?
Yeah, it's low confidence because it doesn't have the pathognomonic features of either of them. I mean, it has like a homogeneous pattern, and so you kind of start to go on type 1, but then it doesn't have the classic vessel or lacy vessel. It becomes confusing. It's like mixing the two. And so when you start to just like try to think it through too much, it means that the features aren't striking and that you likely have low confidence then. And this is something that pathology can help us with more than our optical diagnosis.
Okay, next slide.
So Roy, we have another 14 cases.
Yeah, maybe we'll do 5 more cases.
Okay.
Okay. Paul, please.
All right. Actually, I'm glad that everybody is getting better with their diagnosis.
It's true. And I think everyone had high confidence, which I get, but, and please, I think we should strive for high confidence, but we need to recognize not every polyp will be able to get us there. I think that's important. This clearly did. It has the classic features of type 2.
Okay. I wanted to ask you, Raju, to bring us to case number 16.
Okay, all right.
Okay. That's Paul. Okay. So this is a type 3. We said it there. Let's see the NBI of this, Raju. Is there one? Okay. So this is the NBI part. Now, if you can go back to the white light, go back. So this polyp is the way we diagnose in the NICE classification is that you find the worst pathology. So here is a mixture. Some part has adenoma, some part has cancer. So then you say, well, I'm correct, he has type 2, but he has also the type 3. But in the NICE classification, we need to emphasize that it is based on the most worrisome pathology. So this is type 3 cancer. Okay, we can go to the next slide. Actually, let's go back to case number 14.
I can't go back.
Okay, not go back. Yeah, just go to next one and we'll do a few more cases. Okay. Let's go quickly. Great. Next slide. Oh no, there's like think about the pathognomonic, guys. Let's think about pathognomonic. What's pathognomonic here?
It's pale and has lacy vessels and no pattern.
Okay. Next. Next. How about now? Who's going to discuss, Ravi?
It's pale and we see the lacy vessels like previous polyps. So
Okay.
it's going to be a hypoplastic polyp.
Next slide. Oh no, it's more confusing now. What do you think it is?
I think the question is, are those lacy vessels or not lacy vessels? That's where my mind goes first, right? And then
Yeah.
once you decide that, then you know.
Why is it not lazy vessels in your mind?
Because they go around each of those.
They make a complete journey
Yeah.
rather than just a line sitting there without a purpose.
Mhm.
Okay, next. Next slide. This is something.
Mhm.
Okay. Thoughts?
It is pale.
There are no blood vessels on top.
Okay. I think we may have to wrap up, unfortunately. But we wanted to share these thoughts on how we all can improve on our optical diagnosis. Certainly, doing this in one session is probably impossible, but maybe we'll do another session of pure practice, but we do hope to develop this into a digital platform that everybody can just practice by themselves. Now, we have also shared with you a limited few of the NICE classification to get people going and improve. But please note that we haven't touched about the serrated lesions. The serrated actually has many more pathognomonics, and they are much more easier. They are included in the NICE type 1, and hopefully we will get to that in the next session. So thank you, Raju.
All right, thank you. There's one question from Rajiv Shandy. Can dye-based chromo help in low confidence lesions before biopsy?
Can you use a regular chromo to help? It
Low
could.
confidence cases.
Yeah, but it could. It certainly could. You know, the purpose of the image enhanced using the equipment base is that we wanted to streamline to make it easier to perform optical diagnosis. If we use the dye for more of the simpler type of pathology, then we would negate that. It certainly could, but we wouldn't recommend it. We would use more of a dye to confirm depression or maybe borders. There are other things where we would use dye, but it is not for that. It would be more for the high-end pathology.
Another question, Roy, what is the smallest lesion that can be diagnosed as an adenoma?
With our current system, probably 3 millimeter.
All right.
Yeah, 3 millimeter. Okay.
And
Any
another
other question?
Yes, another question. Using different scope companies. So how do we classify polyps with the Fuji scopes? Somebody wanted to know.
The Fuji scope has the similar physics of their blue light imaging, so that gives you a similar type of findings. As I you know, personally believe that the NICE classification is valid for blue light imaging because of the similarity of the physics, or the similarity of the results of the physics that they use.
Regardless
Sriram,
of which company. Okay.
go ahead, Shalvi.
No, go ahead.
Sriram, why don't you share your thoughts
On what?
on what you sent to everybody about this one image every session? I think that's a good idea.
I was just wondering, because this is such a beautiful session, and as Roy said, one session is not good enough, and it is matter of image pattern recognition and training the eye. I think it will be a very good idea, because you are conducting these sessions every week. If Roy or someone can project one image and leave it for people to think, and at the end of the session to discuss about it. So at the beginning of the session, you could project it for a couple of seconds while you are introducing the topic of the day, and maybe towards the end, you can end the session with the discussion on it. as just a thought.
No, I'm glad. I think I will try to incorporate that. I think it's a good idea. It's a really good idea because it's hard to assimilate everything in one session and to do it every week so that people get into the habit. I really appreciate that idea. We will
Especially
wrap
because
it up.
this is the way to do it. This is our bread and butter, colonoscopy screening for polyps.
Right.
Okay.
So we want to wrap it up with one thought that is basically, I would like to encourage you all to get into the habit of recording your videos and get into the habit of taking pictures and also get into the habit of removing the details on the screen, especially the name of the patient, the endoscopist, the date, the time, so that when you share that video for publication, your video will be very clean and will be more acceptable to the reviewers and the editors. Something to keep in mind. And I want to thank Selvi for conducting the poll. We actually had to rush through quite a bit. Selvi, I appreciate you keeping up the speed. And Roy, thank you. Sylvia, thank you. Ravi and Tanya for sharing your wisdom. It's really helpful, and I think it's a good idea that we will include a little bit of optical diagnosis by introducing one case, maybe with a short video that I will record and bring it, and you could discuss that. With this, we will close the session, and I want to thank everybody for participating in this wonderful session. Thank you, Roy. Thank you, Sylvia.
Thank you so much. Thank you, everyone.
Thank you, everyone.
Thank you.
Great to
everyone.
see you all.
Share.